This program is brought to you by Emory University.
Good morning, everybody. Happy Friday. Coming down towards the end of the year and our Friday morning conferences, just a few more of these. This morning, our speaker, for those of you that have not yet met him, is Francisco Aguilar. Francisco's a first-year fellow in the clinical track. He did medical school in his home country of Venezuela, and then his internal medicine residency at Albert Einstein Medical Center in Philadelphia. And as you can see, he's going to talk to us today about carcinoid heart disease. Take it away, Francisco.
Thank you so much, Dr. Williams, and good morning to everyone. I apologize in advance for my accent. It's going to be a little thicker at this stage, but I'll try to do my best. I want to start the talk on carcinoid heart disease with no disclosures that I should talk about. I want to thank Dr. Lucia Alvarez and Dr. Nick Shakalazzi, who made possible for me to talk about this and have a great feedback to how to construct a good talk and presentation. This talk is inspired on a patient that we took care at the Emory University Hospital at Midtown, and she was a real fighter. The objectives for this talk are describing the epidemiology, clinical presentation, and natural progression of the carcinoid heart disease. We want to also review some of the evidence on the management and outcomes of carcinoid heart disease. And lastly, I will touch base into the evidence for the emerging transcatheter therapies for pulmonic and tricuspid valve disease, which are the most commonly affected in these patients. I'll start with the history of present illness. Our patient is a 72-year-old female with past medical history, including essential hypertension, obesity per BMI, and she was recently diagnosed with metastatic ileocecal neuroendocrine tumor. She had metastasis to the liver and bone, and presents with shortness of breath and bilateral lower extremity edema. In her case, the physical examination, the vital signs were grossly unremarkable. On exam, she presented bilateral temporal wasting, suggestive of rapid weight loss in the prior weeks, as she also disclosed. She had JVD, Lancisis sign positive that we're going to see in a bit. What is it? And bilateral crackles and auscultation with severe bilateral lower extremity pitting edema, suggestive of volume overload. Her labs were remarkable for a creatinine that was 1.8 from a normal baseline, and NT-proBNP was 381 with a normal troponin. Her EKG presentation was not very striking, sinus rhythm. She had a right bundle branch block. Other than that, not very specific findings, but we'll discuss a little bit about this later on. Her echo on the admission, this is a personal long axis view where we see right off the bat that the patient has what it seems to be a large right ventricle, a thick LV, and it has at least a mild pericardial effusion. We see that the valve, at least the mitral valve, seems to have a good motion. And on Doppler, you see the aortic valve has some AI and maybe some restrictions as well. We have on the short axis view more of that LVH, a little bit more of that effusion that we talk about, probably mild to moderate. But I want to direct your attention to the RV, which can have some trabeculations, but in this case, it's a little bit more than we expect for this level of cut. We have what it seems to be actually thickening of some of these chordae or subvalvular apparatus. This is the RV inflow view, where we can see clearly how the tricuspid valve is pretty much non-mobile. It looks a little bit thickened on this view as well. And on Doppler, you can clearly see that there is a big tricuspid regurgitation jet that it's, of course, caused by this immobility of the valve. And this is some of the Doppler, the CW on across that tricuspid valve. And one of the things to recognize importantly is the dagger sign, which means a rapid equalization of the pressures across the chambers. More of this findings on this apical four-chamber view. We see, again, the RV. You can see clearly in here how that thickened subvalvular apparatus is present and is evident with a non-mobile tricuspid valve, more of that tricuspid regurgitation jet you can observe here as well, and more of that dagger sign. This is the RV outflow tract view where we can see the patient's pulmonic valve. The structure, it's also thickened, not very mobile. And on Doppler, you see a significant pulmonary regurgitation, which can be evidenced in the continuous wave Doppler on the right panel. And I want to direct your attention to what we describe as a sawtooth pattern of pulmonic regurgitation, also indicating severe PR. We perform a transesophageal echo to understand a little bit better the findings. But again, we see more of what we saw already on the transthoracic. This tricuspid valve looks very thickened, and compared to the mitral valve, you see the difference in mobility. It's significant. I want to mention also in the apical four-chamber views, you can see the right atrium is significantly dilated as well. More of that TR on transesophageal. This is a view of the pulmonic valve. Again, the structure, it seems to have some mobility to it, and but the regurgitation is clearly significant on the Doppler. So we admitted the patient to the floors and tried to diurese her aggressively to volume optimize before performing a right heart cath to understand a little bit better her pressures and hemodynamic component. And I apologize I did not bring the original tracings, but this is a very similar tracing as hers. You have here two pressure waveforms. One of them is for the RV and the other one is for the right atrium. I want to direct the attention to the right atrium. You can see clearly that the pressures are elevated, but more than that, you have a CV wave. It's giant. It's fused. You don't have any X descent since it disappears because of this, and it appears or occurs right after your systolic ventricular systole. This is described. This is actually the original description of her right heart cath. The right atrium was 24 millimeters of mercury on the ventricular pressure with giant CV waves, consistent with very severe TR. Her other pressures at this point were like kind of optimized from the diuresis. Her mean pulmonary pressure was 20 and her wedge was 13, which looked better, likely better compared to when she came in. As a reference, this is the normal pressure waveform that should be seen. I want to talk a little bit about carcinoid syndrome itself. So in epidemiology, we know that neuroendocrine tumors are rare. Only 1 to 2 per 100,000 people in the general population per year will develop them. Most commonly, they present in the GI tract, and embryologic origin is the midgut. So we talk about midgut carcinoids, and some other areas where you can find neuroendocrines are in the lungs, and they're coming from the foregut. You can also find in the ovaries or any other GU tract. That we'll talk a little bit about that. The midgut origin are the ones that most commonly secrete vasoactive substances, and most of these substances are inactivated by the liver enzymes, including the monoamino oxidase. In certain scenarios, you have either metastasis to the liver, where then the secreted substances obviously bypass those enzymes, or you have maybe overwhelming production of these substances, and they can pass into the general circulation. These are mainly driven by serotonin, but you have also histamine, bradykinins, or prostaglandins playing a role in the pathophysiology. So up to 30% of patients with the midgut neuroendocrine tumor will have carcinoid syndrome, so a third of them roughly. And of the patients who have carcinoid syndrome, 20% of them will develop or will have carcinoid heart disease at the time of diagnosis. But we know actually from following these patients that more than half will develop during the course of their disease. So we'll talk a little bit more about the screening and if we are really doing a good job in that part. The pathology finding is what we describe classically as the carcinoid plaque. There are deposits of smooth muscle, myofibroblasts, and elastic tissue that are triggered by these vasoactive substances. And important to mention, the native or underlying tissue is unharmed. On the images, we have microscopic specimens of a pulmonic valve. In the bottom picture, you can see the normal pulmonic valve, how it's translucent, thin cusps, should be that way. And the top picture, you have the changes, the fibrosis and the carcinoid plaque deposit, how it thickened and restricts the function of the pulmonic valve. In the bottom picture, you have actually a microscopic view of this same kind of lesion. This is a cord actually that we're looking at, and you see the plaques highlighted on a black arrow, and the underlying tissue in the middle had no inflammatory cells and had no disruption of the histology. The evidence of linking these vasoactive substances, especially the serotonin, comes from initially from human observational studies in some animal models. Actually, these pictures that you're seeing are from a publication on patients who were on fenfluramine and phentermine, which were serotoninergic drugs that were withdrawn from the market. They used to be indicated for weight loss, but we noticed that patients develop valvular heart disease very similar to carcinoid heart disease. The distribution, it goes with the flow. The most common affected valves are the right-sided valves, tricuspid first, then the pulmonic valve first. We have rarely left-sided valves are affected, less than 10% of the cases, and we believe it's because of inactivation of in the lungs by the monoamino oxidase. And if they're present in a big majority of cases, it's because we have a right to left shunt that we have to investigate further. In certain scenarios where you don't have a right to left shunt, it may be the overwhelming production of the substances that cannot be all removed by the lung enzyme. The clinical presentation is important to mention that actually most of these patients who have carcinoid heart disease and associated moderate to severe TR are asymptomatic or have mild symptoms. So the clinical presentation can be misleading, and we need to probably do a little bit better in order to start screening for carcinoid heart disease. The exam, nothing striking. You can have some findings from the severe TR, prominent CV waves, that's the Lancisi's sign, and I'll show you in a second. RV heave and systolic murmur, it's difficult to hear given the low velocities on the right side. Similarly with severe PR findings, like a diastolic murmur in the left second space, which is probably more likely to be on the boards than the ability for us to hear in real life. For our practice in general, the Lancisi's sign, as you see here, is a giant CV wave on your venous pulse. And you can also see sometimes if you have a CVP pressure line on the monitor, those giant CV waves. The diagnosis of carcinoid heart disease, it's mainly driven by echo, as we're gonna talk about, but we have no specific changes on the EKG or chest X-ray. As we spoke on the EKG, we can find some RV strain signs like right bundle branch block, some enlargement of the right atrium or RV, but nothing specific. Biomarkers have been investigated, and now they are actually accepted, especially the NT-proBNP as a marker for screening and prognostication, and even for follow-up. we have the original report that started investigating these two in more detail for this population was in 2009, where they showed that NT-proBNP in 100 patients with neuroendocrine tumor had a sensitivity and a specificity over 80% when you use a threshold of 28. Just to refresh, our patient had 380 BNP. As I said, the gold standard is transthoracic echo. We saw most of the findings that are classically described as thickening of the valve with diminish of the curvature and altered motion of the valve with fuse and shortened chorda or all the subvalvular apparatus being affected. Most of the time you have regurgitation of these valves, but you can have some stenotic component to it. Other than the valves affected, you can have a dilation of the chambers that we talked about. And lastly, you can sometimes see metastatic lesions in the heart. I want to bring that there is a specific PET scan for identifying metastatic lesions. That is a totate gadolinium PET. This is a somatostatin analog that can light up some of these lesions. This is just to refresh the findings on our patient that clearly have most of them. It is important to always evaluate for a right to left shunt in our patients when we start with an echo, since that can predict if the left-sided valves are going to be affected, and actually in some cases can guide therapeutic management. For follow-up, there is no clear guidelines, but the expert consensus in America was in 2017. They published some guidelines saying that if you don't have any carcinoid heart disease, just the neuroendocrine tumor, an NT-proBNP every 6 months to a year should be sufficient. And if you have carcinoid heart disease, depends on the severity, you can do a transthoracic echo every 3 to 6 months. The European expert consensus actually met, I think it was 2020, and they recommend similarly as the Americans, but the echo a little bit more space, like every year. So what is the natural progression of these patients with and without carcinoid heart disease? And this is a report from the SwissNet cohort. It's a Switzerland, 1,800 patients with neuroendocrine tumor, where we saw that 6% of them had carcinoid syndrome, and from those, 21% had carcinoid heart disease. The overall survival, and I want to direct your attention to the top left panel. You see that it obviously is not good. The top line is the neuroendocrine tumor patients, and the bottom line is the neuroendocrine with carcinoid heart disease. We can see that around 5 years, the survival difference is significant. And these investigators tried to look a little bit more into why is that? So they identify on the panel B on the top right side of the graph 3 groups. There was a group A who was diagnosed early with carcinoid heart disease at the time that neuroendocrine tumor was diagnosed, but they did not live long. There was a group B where it was similar timing of diagnosis, almost simultaneously, but they lived longer. And they have a group C where they were diagnosed with neuroendocrine tumor, but the carcinoid heart disease was diagnosed later on in a median of 4 years. And those patients we can see on the bottom left on the C graph, the survival following that neuroendocrine tumor diagnosis. The group A and group C did not do well. And the conclusion of the study is pretty much a group A is likely patients who presented late, and they were diagnosed both neuroendocrine tumor and carcinoid heart disease in a probably end stage status. And the patients in group B who live longer are likely those patients who were captured early. And I think that's the main take-home message, that we need to be more aggressive into screening these patients for carcinoid heart disease. Otherwise, it will affect their survival rate. Speaking of management, it is complex. It has a multidisciplinary approach, as we know from cardio-oncology, CT surgery, interventional cardiology or structural cardiology, and oncology and heart failure. There are a three-prong approach that it's a consensus that diuretics is a no-brainer for management of volume overload. And I'm going to touch a little bit on the somatostatin analogs or tumor control strategies. But I'm going to dig deeper into the valve repair or replacement evidence. For the somatostatin analogs and tumor control, we know that in spite of the strategy that you use, either medical or chemotherapy or surgical resection or embolization of the tumor, of the neuroendocrine tumor, you still do not regress the lesions that are existing in your valves. So that's important to mention. It does predict the development of new abnormalities. So you can stop the progression of the carcinoid heart disease, but you cannot regress the lesions that are present. And this is an important factor because these could be patients that have a target for therapies on replacement and repair of these damaged valves. Ovarian carcinoid tumors have a special flavor to it since they can cause carcinoid heart disease without liver metastasis, and that has to do with the venous return bypassing the liver. Also, some of them have retroperitoneal metastasis that can also actually bypass the liver. And similarly, in these patients, you can have a resection of the ovarian tumor and could be curative of a carcinoid syndrome, but the carcinoid heart disease do not regress. Now, surgery or management of this valve in a surgical fashion, it has been studied for a while. This is one of the first publications of a case series by Dr. Connolly, who is an expert in the field in 1995 at Mayo Clinic. She published a 26 patients experience where a third of them died perioperatively at that time. A third of them died what we call late death, but it was within a year of intervention, and a third actually lived to a mean of 28 months. So not great outcomes after a surgery. Most of these surgeries were tricuspid valve replacement and pulmonary valve replacement. And we see on the survival that initially the patients, of course, in the surgical part did worse, but over the years, those who survived actually did better and lived longer, saying that there is a role for this valve intervention and patients who are actually selected properly. They also had a significant improvement of the NYHA symptoms, and we'll see a little bit more about that. Dr. Connolly later on published as well multiple data on this issue, but another element to mention is what type of valve it's better. And there was a trend of bioprosthetic or tissue valves to have more survival and less complications. And the consensus, to be honest, nowadays is that we use bioprosthetic over mechanical valves in all the occasions for carcinoid heart disease, especially because these patients have the right-sided valve has thrombosis, as we know, but also the carcinoid syndrome patients have increased rates of GI bleeding, and that can be also one of the problems. So how can we help our patient with some of this information that we have? So let's try to go to the guidelines. That's what I naively looked into that. And when you go to the 2020 ACC/AHA guidelines on the pulmonic valve, they just say, just go to the adult congenital heart disease. And I say, okay, well, let's go to that. And these are the 2018 AHA/ACC guidelines. And I clearly find no pulmonic valve disease guidelines, and it's just breaking down by each pathology. And I understood that most of this evidence comes from tetralogy of Fallot patients. In the 2021 European guidelines, is a similar thing. You don't have a pulmonic valve section since most of the adults do not have significant pulmonic valve disease. So for PR, especially, we know these tetralogy of Fallot patients that if you leave it untreated, they will have RV enlargement, systolic dysfunction, arrhythmia, and eventually die. And in places who have an expert surgeon, a surgical pulmonic valve replacement has less than 1% periprocedural mortality and more than 60% freedom of reintervention at 10 years. So surgical options are very well accepted and established, but in our patients with carcinoid heart disease is different since they are older, they're sicker, and probably some of them actually are not a surgical candidate. The transcatheter replacement of the pulmonic valve is reserved for high surgical risk and some valve-involved cases, but again, the evidence is limited. Who do we treat with pulmonic valve replacement? We treat the patients who have severe PR and they are symptomatic. That's in the 2018 congenital guidelines, again, from the tetralogy of Fallot section. Patients who are asymptomatic and have 2 out of 4 criteria. Some of those criteria are pretty much RV or LV dysfunction, very high RV systolic pressure, RV dilation, or some reduction in exercise tolerance. Bioprosthetic valves, as we mentioned, are clearly preferred over the mechanical valve, and they have now a longevity of around 15 years after implantation for the pulmonic valve. For pulmonic valve, we said that some transcatheter options are available and their exclusion. We don't typically implant pulmonic valves transcatheter in patients who have severe pulmonary stenosis, given the anatomy is not suitable for deployment of the valve. Also, RVOT conduit size is an important element that applies mostly for the congenital heart cases. Lack of venous access for deployment, this is a transfemoral approach, and we will see a little bit later on this. Why is that? Also, any active systemic infection or risk of endocarditis. And lastly, I want to highlight because of the position of the valve and anatomy and in relationship with your coronary artery, especially the left system, you have a risk of coronary compression. We do what we call a balloon test. The valve options for the pulmonic valve transcatheter replacement are comes in 2 flavors. They are balloon expandable or self-expandable. The Melody was the first one to be in the US available, but then the SAPIEN 3 came. It's a similar SAPIEN 3 as the TAVR, but it was adapted to the pulmonic valve. And now the self-expandable are taking some territory with the Harmony and the SAPIEN 3 with an adapter. So how these patients who we put a pulmonic valve transcatheter do? And this is what we have in this publication from Jack in 2020. And I'm sorry for the BC graphs, but I'm going to walk you through. I want you to focus on the 29 millimeter size valve. This was a registry of 700 patients using the SAPIEN XD, which is not longer used, and the SAPIEN 3, which was most of the patients in here. You see in the 29 patient column on the top left graph, most of those patients were patients with RVOT that are native, and they were patched, but technically were normal size. That's the important thing. In the bottom left, you see also the distribution of these 29 millimeter valves, which are the indication for it. Most of them were for pulmonic regurgitation, like our patient. Then, as we said before, you can pre-stent some of these balloon expandable valve, and in the bottom right graph, you see that those patients with native RVOTs, more than half were pre-stented to provide a secure place for this valve to sit, and the other almost half were no pre-stented. Now, the outcomes were really good. 97% of the patients had a successful implantation of the valve, with only 1 patient died from PA rupture. And the major or any serious procedural adverse event was around 10%. Then 46% of the patients were able to follow up after a year. And you see that after a year, those patients had low rates of new paravalvular leak or pulmonic valve regurgitation. Only 1.7% of the patients develop infective endocarditis and less than 2% died, most of them from another cause. The important to mention with the stenting and pre-stenting, most of these valves that embolized, which was considered a serious adverse event, were patients who did not have a pre-stenting. So with this evidence and our patient, we decided to go with a transcatheter 29 millimeter sapien 3 valve with pre-stent. Our patient was symptomatic and she was deemed not a surgical candidate. It's a 26 femoral delivery system. Her RVOT was normal. It was actually large in diameter. That's what we meant. We use a CP pre-stent that is used in some cases of congenital and some other intervention. And the valve itself, the sapien 3, is a bovine pericardial tissue that has a skirt to minimize paravalvular leak. And the measurements are best achieved using a structural CT protocol. I'm gonna show you a pic of the software that we use for that. These are some of the slides of her intervention. You can see in the pulmonary angiogram how there's significant pulmonary regurgitation. And I want to direct your attention to the catheter that is at the back of the slide, which actually is engaged into the left coronary system. And you're going to see that we're going to do a balloon testing in this case. This is where we're starting to expand the balloon, and we are testing when we expand the balloon, we inject the coronaries and see if there is any obstruction. I apologize that there is no I don't have the images where we inject the contrast for the coronaries here, but I'll show you in here. This is now that we tested the balloon, we go with the stenting, the pre-stenting, and then you can see how the stenting is aligned to be deployed at the right position, with the neck being at the level of the pulmonic valve. Here we have the stent deployed, and you see how we shoot the coronaries, the left system, to make sure that there is no obstruction or impingement of any of the coronary arteries. Here we're deploying the valve, the pulmonic valve, and in here is already deployed, and we're looking at the angiogram how the results of the valve went. And actually the PR, it's completely resolved, if you can see. This is part of the structural CT protocol, the software that we use. In this case, it was a picture of our patient, but after she got that deployed. You see how the softwares allow you to different cuts or views of the pulmonary artery. You can rotate 3D as well, and you can have short axis views to measure perimeters and also length in order to prepare for this deployment. These are the results of the transesophageal echo after we deploy the pulmonic valve, and you see how the PR is pretty much resolved. Now, we need to go now with how can we help our patient's tricuspid valve in this case, and it's left over. We have patients who have a tricuspid regurgitation. We know that they do worse regardless of their disease, even if they are isolated. We know that patients with TR and heart failure do worse, regardless if they're prevalent or new TR. We have a classification that has been actually challenged nowadays to the expansion of this severe category into massive and torrential, and those patients who have a vena contracta more than 7 millimeters with an EROA of more than 40 millimeters square as well. And we know that these patients now on the trials are looking into those extra categories. For the tricuspid regurgitation guideline, the 2020 ASC-CAHA just mentioned about the time of the timing for replacement or repair of the valve is mostly on this left-sided valve surgery, since we know that they progress worse. This is a class 1 recommendation and is mostly for annuloplasty. In patients with symptoms in primary TR, like our patient, is a class 2A or 2B to intervene if they have any RV dilation or systolic dysfunction. This is similar to the European recommendation. They go by the RV dilation or symptoms and the need of a left ventricular valve replaced. Important to mention, the surgical tricuspid valve replacement outcomes are bad. They have around 10% mortality in hospital peri-op. So in spite of the improvement of the techniques from 1995 publication to 2020, it is still a high death rate. So it's always a dilemma about when to do this intervention. The dilemma is going into too early, given this high in-hospital mortality, versus too late, given this complications from the TR over the years. So we have transcatheter options. Our approved is the edge-to-edge repairs and also the transcatheter replacement of the tricuspid valve. But unfortunately, the edge-to-edge, because of anatomy, we know is not suitable for patients with carcinoid heart disease. So tricuspid valve replacement is a possible option in those who have high surgical risk. An expert consensus was from the 2022 European guidelines say that also if you plan to do any surgical intervention of the liver metastasis, an upfront valve replacement of the right-sided heart should be considered to prevent some pulsatile liver and complications from bleeding. Lastly, I want to talk about the system, the transcatheter system that was studied for these patients with TR, with severe TR, and that's the EVOQUE system. They have the TRISCEND trial initially was for compassionate use, and then they published a 30-day and the 1-year results. It was a single-arm prospective multi-center where they evaluated the safety and performance of this valve, the EVOQUE, and it is a 28 femoral transfemoral French system that is being used for primary and secondary TR on those patients who have elevated surgical risk. Contraindications to this, to mention other than the anatomic problems, it will be severe RV dysfunction, since we know that these patients, at the moment that we deploy the valve, it is such a change for the RV that it can actually cause an acute stress and decompensation, an RV failure. The results and the outcomes of these 3 trials are great in terms of the NYHA class improvement and TR improvement. They sustain after a month and even after a year with low rates of mortality. 30-day mortality is 1.7% in the real scenario, in the real world scenario, and 1-year mortality of 9%. It's important to mention that only 10% of the patients in these trials were primary TR, so it's something to take into account. The TRISCEND 2 is coming up. Dr. Han actually mentioned that in October it will be published, some of the results. These are comparing this valve versus an arm of medical therapy alone. I'm gonna just skip the video of how we deploy because of the time issues. And in our patients, unfortunately, we could not deliver the system given the metastasis that she had in the liver. It could not pass through the liver or the IVC. Ultimately, our patient was discharged home pending a home hospice decision and with the primary and the oncology team. Thank you so much.
Thank you, Francisco. Very good review. I guess one issue, and a lot of times the cause of death in these patients, you mentioned, is the RV dysfunction, and the thought is, that carcinoid doesn't just impact valves, but it probably impacts endocardium at least, and if not endocardium, myocardium of the right ventricle. So, any thoughts on that, or other, obviously fixing the valves are the big thing and the things that need to be fixed, but other thoughts or therapies in terms of the sort of endocardial, myocardial aspect of this disease?
Yeah, it is. The thought is that most of the element is a hemodynamically component from this valve disease. And as we said before, the carcinoid plaques tend not to affect the underlying tissue. And the problem is that most of these patients, we intervene or treat too late in the disease, and some of these changes are non-reversible at that point. And we know that the RV consequences that these patients have, they end up translating into the LV as well. And at the time that we are acting, it's too late. The message from all the different sources that I could read is that we need to do a better job in screening and early detection of these patients and aggressively managing, especially those patients who achieve remission and of their neuroendocrine tumor and have initial valve lesions and to prevent these consequences. And that's a trend that is changing right now.
Other thoughts or questions from the audience?
Francisco Stan Sherman, good job. Was there a recommendation about biomarkers in patients who have newly diagnosed neuroendocrine tumors, no matter what, whether their echo's fine or not fine? Did they say, go ahead and get these biomarkers early?
Yes, that's correct. Thank you so much for your question, doctor. They recommend that you actually should, at the moment of diagnosis of the neuroendocrine tumor, you should check for NT-proBNP. And if that's still below 28 or 26, depends on the expert consensus that you use, you still have to recheck them every 6 months to 1 year to screen for carcinoid heart disease. If you have a patient with carcinoid heart disease already diagnosed, you could use the NT-proBNP to assess, as we do for the heart failure patients, but they actually recommend is jumping into a transthoracic echo every 3 to 6 months to assess the progression of their valvular disease.
Okay, well, again, a fantastic review, and thanks everybody for tuning in this morning. Thanks again to Francisco, and if there are no more comments or questions, we'll see everybody next week.
The preceding program is copyrighted by Emory University.